All right. Chapter 21. Pre-labor complications. So the first thing we're going to talk about is premature and preterm rupture of membranes. Two different deals. So, or wait a minute. No. Yes. Okay, I'm sorry. Confused. So, preterm labor or preterm birth or preterm anything is 20 to 37 weeks. If it's before 20 weeks, what is it? Abortion. If it's after 37 weeks, this might be a future lecture, but so they divide, or did we talk about this? Early term, okay, all right. So anyways, preterm is 20 to 37 weeks, and we instruct patients to look for signs for preterm labor. One of which is she has at least 4 contractions in 20 minutes. Or 8 in an hour. But if she's starting to contract more than 4 in 20 minutes, then she needs to come in and be evaluated. Or a cervical dilation change greater than 80%. That's textbook, okay? But if they're having consistent dilation change during the preterm, I don't care if it's 80%, if it's consistently dilating, if it's progressively dilating, then she's in preterm labor. Okay. So, if she starts having regular, consistent uterine contractions every 10 minutes, with or without pain. So, I mean, uterine contractions you can feel, and they're not always painful. It's just like a cramp. If she's feeling that at least every 10 minutes consistently, then she might want to call and be examined. If she starts having pelvic pressure, so that's a sign that baby is moving down into the pelvis, getting close to the cervical os where we don't want the baby preterm. If she has rupture of membranes, okay, she might not start laboring, she might not contract, but if her water has broke, then that's a problem, and we need her to come in, okay? She could complain of a very vague low back pain. She could have cervical discharge and abdominal cramping. Some of her complaints can be super vague, and they could just be common pregnancy discomforts, but we don't know until we evaluate her. So, sometimes we'll tell a gal that calls, I'm just feeling kind of crampy, back's aching, I don't know what I should do. Well, drink a big glass of water, take a warm bath, put your feet up, relax for a little while, and if you're still having those symptoms, you should probably definitely come in, okay? The drinking of the water hydrates, creates more blood volume, so the uterus is very sensitive to dehydration, and will just maybe start being irritable if someone's dehydrated, but not necessarily meaning that they're starting into preterm labor. So we tell them to drink lots of water. The warm bath kind of just relaxes, so if her uterus is irritable for some reason, a warm bath can just relax her uterine muscles, and that may go away. If she's had a lot of activity, been up running around, doing housework, taking care of other children, maybe she works a job, it could have irritated the uterus. Just that activity could have irritated the uterus. And if she just lays down, puts her feet up, and relaxes a little bit, sometimes that goes away. So every time a patient calls, it's very tricky. There's a very fine line in you telling them to stay home or come in, okay? But if we was to tell every woman that called and said, I don't feel good, to come in, we would be overrun daily by multiple patients. So we do try to triage them a little bit. We tell them to only give it an hour. and if they're still having those complaints, to come in. But if they are calling and saying, I'm having contractions every 2 to 5 minutes, I'm leaking stuff out my vagina, I'm rating my pain an 8, like, come in right now. Like, there's no time to waste, okay? So here's your risk factors for developing preterm labor. So infection could just be a UTI. We get gals coming in that are contracting, bam, 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 every 2 minutes. We send their urine down and they have a UTI. We treat the UTI, the bam, bam contractions go away. So some of these things that happen, we can try to fix. But some of them are serious issues and we won't be able to fix them. They may have to be on bed rest. They may get admitted to the hospital. If they're 24 weeks and they're having some of these problems and we can't stop their labor, or the only way we can stop their labor is a continuous infusion of medication, they could be in our hospital for months, weeks and months. We try to keep them pregnant as long as we can. So of course our goal is to maintain uterine blood flow. That's our goal no matter what, every patient, preterm or term. We want to maintain good uterine blood flow. If we maintain good uterine blood flow, then we're oxygenating our baby, okay? We want to try to stop contractions and then make sure the baby is doing okay. So, maternal lateral position, so left lateral. Now, we say for pregnant women, left lateral, left lateral, left lateral, and if you guys remember, left lateral does what? Takes the pressure off the vena cava, okay? But some women, I get in and I put them on the left side and baby hates it, okay? And baby tells me they hate it because their heart rate looks bad. And then I flip her over to her right side and everything's better. So it's not a magic, this will fix all problems, but it is usually the side we go to, left lateral. IV infusion, again, we're increasing blood volume, so we're increasing blood flow to the uterus, and also hydrating the uterus. Like I said, the uterus is very sensitive to dehydration, okay? So we'll draw some labs to see what's going on. The C-reactive protein, we don't commonly do that, but some practitioners do. It's a practitioner choice, okay? We might do cultures to see if she's got uterine infection. And then the fetal fibronectin is a test that we do. It's not relatively new. I mean, it's like within 10 years we've been doing it. But if we did this protein, then the likelihood of her going into labor within 2 weeks is very high. So if she has a positive fetal fibronectin test, then we say she's at risk for going into labor within the next 2 weeks. If it's negative, then we say that her likelihood of going into labor in the next 2 weeks is very minimal. And then we'll do ultrasounds. So we look for cervical length. Now we like to do the ultrasounds and look for cervical length on a preterm woman because we don't want to stick our fingers in there and muck up everything and cause a potential problem, okay? So we would prefer to do an ultrasound to look at cervical length. If, the cervical length should be long, and if they determine that it's really shortening or funneling, so basically looking like a funnel, then we're concerned about her going into labor. And then we'll also look at the baby and the placenta and make sure that there's no issues stemming from the baby or the placenta. So once we've detected contractions, we will try to stop them, and we can use several different medications. Breathine or terbutaline is actually an asthma medication. but it's been shown to relax smooth muscle, so we try that. It's a sub-Q injection, and we give 0.25 milligrams sub-Q. Um, we so some practitioners will go straight to breathing and some won't. Breathing is short acting. We can even send these patients home on an oral dose to be taken like every 4 hours or as needed for contractions. But it causes anxiety and increased heart rate in moms. Like they feel like they're having palpitations and they can't breathe. And so some people just don't like to use it because it just causes craziness with mom. And then it also causes tachycardia in baby. So tachycardia is not a good heart rate to have in your baby. And then we've caused it with breathing, or did we cause it with breathing, or is there a problem? So who knows? Okay, so we really don't like to use breathing as much. Mag sulfate is an IV drip medication. It's a continuous infusion. So if we gave breathing and we stopped her contractions, we could probably send her home. But if we're starting mag sulfate, she's an inpatient. She's been admitted. Okay. So we run mag sulfate. It's a very, very dangerous drug. It's a black box drug. It requires 2 RNs to verify. We give a bolus loading dose. In 20 minutes, we'll give about 4 grams, okay, in 20 minutes. And then after that bolus is done, we set her up with an infusion, a continuous long-term infusion of 2 grams, okay? So 2 grams an hour and 4 grams in 20 minutes. So this woman will immediately feel like crap. This medicine makes you feel sick, yucky, horrible, hot flush, headache, vomity, yucky, okay? And then we slow it down to 2 grams, and that feeling kind of resolves a little bit, but they've sometimes always got this feeling of yuckiness, okay? Mag sulfate is a very dangerous drug, so when someone's on mag sulfate, we're doing continuous assessments. We're looking at their level of consciousness. We're looking at their respiratory status, their rate, and their lung sounds, their oxygen saturations. We're watching their kidneys, so we're looking at their output because it's excreted in the kidneys. And then we're watching their deep tendon reflexes. So if we start giving too much mag to our mom, then we're going to start decreasing her level of consciousness. We're going to start slowing down her respiratory rate. If her kidneys are not processing the mag, she's going to start third spacing fluid, okay? We're going to relax her central nervous system, so we're going to start losing our DTRs. If those things start happening with your frequent assessments, then you know she's getting mag toxic. Okay, we're giving her too much mag. Now, usually on a 2-gram maintenance dose, healthy pregnant women don't usually get toxic, but we can run magnesium up to 4 to 6 grams an hour. And when we're doing that, then we're getting very close to being toxic or causing our patient to be toxic. So we need to be doing very frequent assessments. Some practitioners will do a serum mag level every 6 hours, and that kind of sucks, especially if she's on mag for 24 to 48 hours to be getting poked every 6 hours. So the RN assessment, if it's done frequently enough, should be telling us what our mag levels are. Now, when you do a mag level, normal magnesium levels for a non-pregnant adult person is less than or equal to 4. Okay. Therapeutic mag levels for pregnant women are 5 to 8. Okay. So if we did mag levels and we got a patient whose magnesium level was 7, lab will be calling us and saying, I got a critical lab value for you. And you would be like, oh my God, what is it? And they would say her magnesium level is 7. And then you go, oh, fabulous. And then lab hangs up the phone and thinks you're killing the patient. But for pregnant women, we want a therapeutic range between 5 and 8. Now, the other thing we might try is a prostaglandin inhibitor. So prostaglandin plays a role in um, labor. So we want to inhibit that. So indomethacin is a drug that we give. It's a PO dose, oral dose. There's extended release, regular release, depending on what the physician prefers. You could get it twice a day, 4 times a day, whatever. And so we put her on that and see if that helps, and then watch her for a while, and then maybe even send her home on this medication. And then the other one is Procardia, very effective in treating contractions, and it has different dosing regimens. So this girl may be sensitive to the dose at once a day, or we may need to give it twice a day, or we may need to give it every 4 hours. So we have to play with that a little bit. Find out what works for the patient we're treating. Okay, so we said if her water breaks when she's preterm, then that's bad. We can't go back. She will be admitted to the hospital, and we will try to maintain her pregnancy as long as we can. But there is 2 terms here. One is premature rupture of membranes. The other one is preterm premature rupture of membranes. Now, the PROM, or premature rupture of membranes, is just their water broke and they didn't start contract, didn't go into labor. So usually this is a term that we link with term pregnancies. So I think Deb was telling me in ATI, there was a question about rupture of membranes, and I can't remember, but someone said
it was something like she came in with her ruptured membranes, and they sent her home to count kicks or something. Mm-hmm. I don't know if anybody else read that, but
so anyways,
it was one of the questions.
So if someone comes in and their water breaks and they're not in labor, yeah, you could send them home until their contractions start. They could be comfortable at home, they can do stuff at home, they can whatever, and then when contractions start, they can come in. Well, the problem with that philosophy is if her water breaks and she never starts contracting, so is she going to stay home for 2 days, 3 days, 4 days? How long? Okay? When that water breaks, the time clock starts. Okay? That is a route of infection, and neither one of the hospitals in this town will send a woman home with ruptured membranes with her contractions not starting. So if she has ruptured membranes and she's term, we will admit her, and if we have to, we will start Pitocin to get her to contract. Okay? But preterm premature rupture of membranes is her water breaks when she's still preterm age, so anywhere between 20 and 37 weeks. And she's not contracting, okay? So it's preterm, so it's before 37 weeks, and it's premature because it's not associated with contractions. And we love that. If we're going to have someone who's preterm and their water breaks, we hope that they don't start contracting, because if they start contracting, then that means they could be dilating and delivering their baby. However, we will try to keep that person pregnant as long as we can. So what did I say about the term patient? The time clock starts, okay? It's really no different with a preterm patient. However, she's admitted to the hospital. She's not leaving until that baby is born. She's going to be on continuous monitoring, both her and the baby. And as long as baby has a category 1 strip, is doing well, that neither one are showing any signs of infection, we're going to keep her as pregnant as long as we can. Because even though her water broke, she's still going to be producing amniotic fluid, or at least the baby is. okay? But if it gets to the point where she's lost too much fluid, baby's not producing enough, and we start having bad baby heart rates, then we might have to consider delivering. Or if mom starts showing signs of infection, then we might have to consider delivering, no matter how many weeks she is. Okay?
So, did you potentially have a mom who's what? She's still
Weeks. Yes. We have lots of gals like, hopefully it's not until 24 weeks because viability is about 24 weeks. As technology improves, viability can be earlier and earlier, but viability has nothing to do with um, um, nothing to do with long-term sequela, okay? So we can keep the baby alive until the baby can live on their own, and then they're going to have chronic medical problems because we did this at 21 weeks, okay? So, anyways, yes, we hope they're at least 24 weeks, and we hope to keep them pregnant until at least 37, 36-ish weeks, as long as we can. So they're in the hospital all that time. Here's risk factors for developing premature or preterm rupture of membranes. Tobacco use, infection, so if she has some sort of infection, especially if it's a uterine or amniotic fluid infection, that's really bad juju. We can't cure that infection. If it's in the amniotic fluid or in the amniotic membranes, we cannot cure that infection because there's no blood supply to the fluid. So we could hit that mom with mega doses of antibiotics, and it will not treat that infection. Okay. Anyways, hydramnios. So hydramnios is what? Who remembers what that is? Too much amniotic fluid. So just the size and the weight of that could cause rupture of membranes. Of course, multiple gestation, same theory. Okay. Low socioeconomic status. So that should be a risk factor for every disease, illness there is, because low socioeconomic status means they may not have the money for proper nutrition, they may not have money for vitamins, they may not have money for a healthy living situation, so that puts their pregnancy at risk. Other reasons, so amniocentesis. So amniocentesis is something that we do to the patient, okay? That is where we stick the needle into the uterus and draw out fluid. Well, a risk factor for that is rupture of membranes, okay? Placenta previa, trauma, incompetent cervix, all those things are risks for rupture of membranes and preterm labor. So also, if she does end up having premature rupture of membranes, that will put her at risk for developing a placental abruption. So that's where the placenta starts breaking away from the uterus in some form. We'll talk about this a little later this morning, and she starts bleeding, okay? So what happens to the baby if we have preterm premature rupture of membranes? So respiratory distress, because if she's preterm and delivered, her lungs are not ready. So of course that's going to be an issue. Sepsis. So if this caused an infection, her being ruptured for a long time and then she got infected, or if she was infected and that caused the rupture, so baby could be infected and get sepsis, okay? So she has the premature rupture of membranes, and it's early in her pregnancy, and that baby hasn't flipped to the head down position yet because it's not time to, so baby could be in any position there. And of course, cord prolapse, anytime a woman's water breaks, no matter how many weeks she is, there is a risk for cord prolapse, premature birth, and bad heart rates. If for whatever reason caused this, we could see that our baby is suffering and have bad heart rates. So we want to determine when the water broke, because again, that's the time clock. Now, if she's premature, of course, we're going to try to push that pregnancy as long as we can, but we're going to be super vigilant in our assessments of mom and babe. We need to know the gestational age, of course. We need to watch for infection. We need to watch the heart rates and prepare them for possible preterm birth. And when that occurs, the NICU team comes over, even if they wouldn't deliver for another couple of weeks. The NICU team comes over, introduces themselves, so takes the parents on a tour of the NICU, and kind of just tries to help reassure them about the safety and quality of care that a baby would receive over there. So she's going to be on constant monitoring of baby and uterine activity, vag exams only if necessary. So like I said, the preterm person or the ruptured person, like we don't want to be having our fingers in there if we don't have to. That's going to just put her at more risk for problems, okay? We're either going to introduce infection or we're going to stimulate more labor, okay? Keep her hydrated, encourage left lateral if that's what baby likes. She'll be on bed rest. Any questions about those things? Okay. All right. Placenta previa. So this is where the placenta is attached in an abnormally low position in the uterus and in relation to the cervix. So there's a couple of different severities of placenta previa. The one big risk with placenta previa is bleeding. So the closer the placenta is to the cervix, the more risk she is of bleeding. Okay, so here's 4 different types. A complete previa is one where the placenta is completely covering the cervical os. Okay, so as that cervix dilates, then it's opening up the placenta to just bleed right out. It's like a faucet. It just turns on and it just starts bleeding, okay? There's absolutely no way a woman can deliver vaginally this way with that placenta coming first, okay? A partial previa is the placenta is just partially covering the cervical os. She still cannot deliver vaginally, and she's still at very high risk for bleeding, okay? A marginal previa is it's just at the border of the cervix. Depending on the physician or the facility, this woman probably will not deliver vaginally either. Because if your cervix is closed and your placenta is right at the border, so it's not over the opening of the cervix, but it's right at the border, and then that cervix starts opening, then it's going to open below the placenta. Now, the low-lying placenta, a woman can deliver vaginally. It's just low in the uterus. It's close to the cervix, and even fully dilated, the placenta would not be exposed, okay? So with a low-lying placenta, she can deliver vaginally, but she's still at high risk for bleeding, and we still need to be prepared and to handle that, okay? So here's what they look like. Here's the low-lying. So you see the placenta is right here, the cervix is right here, and as it dilates, there should be no placenta exposed prematurely. So these women can deliver vaginally. But this is the partial, and it's not a very good, this is almost a marginal to me, but so it's just partially over the cervical os. And then, of course, as this woman dilates, she's going to expose more placenta. And then here's your complete. So before she even dilates, she's probably bleeding. Yeah.
So if you're given a cervical exam, can you feel the placenta then?
Mhm.
Is that...
If it was a complete and even a partial, you would be able to feel that placenta. If her cervix was open for you to get to, or get through. Yes.
Is placenta location detectable in the routine ultrasound?
Yes. Yes. They find these in ultrasound. Usually they detect these early in pregnancy, and then they'll do serial ultrasounds because that placenta could possibly migrate up. So there's a lot of women who first trimester had a complete or low-lying placenta, and by the time they were term and ready to deliver, that placenta migrated up into the uterus and they were fine. Okay. So here's your risk factors for placenta previa. Yes, sorry.
Would there be any adverse effects for serial ultrasounds for developing baby?
No. I mean, I haven't looked at the research. We had this one gal not even too long ago, like within the last couple of months. What were they wanting to do an ultrasound? Her 20-week ultrasound or something, she refused it because of the risk to the baby. So they're so minuscule, like almost not even worth mentioning. Yes.
Did you say that the incomplete or partial could go either way in terms of vaginal or cesarean?
A complete, a partial, and a marginal will not be vaginal.
Okay.
Only the low-lying does the woman have the opportunity to try a vaginal delivery.
Oh.
The marginal was the one that's could be a little iffy. The placenta is not over the cervix, it's just at the border of the cervix. But as that cervix dilates, then it could possibly be exposing placenta.
Okay.
So
I think ATI just lumped margin both lines
together, yeah. Some don't differentiate. Okay. So the fetal prognosis, it just really depends on the amount of bleeding. If this woman has very minimal bleeding, then we're not anticipating any problems from our baby, okay? It's just related to bleeding, okay? Or the amount of bleeding. And then, if she ends up having a C-section, then there's just the, risks of C-section like it is with anyone, okay? Except for, okay, so if she has a C-section, where do they cut for the C-section, usually? Low. Where's the placenta? Low. So they could slice right through the placenta trying to get to the baby. So I guess that makes it more of a risk. All right. Okay. So a complete and partial previa is an indication for a C-section, period. And then if you have a previa and you're laboring and mom's bleeding a little bit more and then baby starts being compromised because of the amount of bleeding mom has, then you will probably go to C-section. So when she has a previa and she's bleeding, she has no pain with it. She may not even be contracting with it, okay? But it's bright red vaginal bleeding, and it's a little more than just a little bit of mucousy bloody show, okay? And she could start bleeding at any time during her pregnancy. I thought you were going to ask a question. The anticipate unengaged fetal presenting part also is related to the degree of the previa. So the more low-lying it is, or the more complete it is, the harder your baby is going to be able to be engaged. Transversal eye is common because there's the big placenta down there, and so it's just more comfortable or easier for a baby just to lay transversely, okay? So we're going to do our frequent monitoring. She's a high-risk patient, so she gets monitored every 15 minutes, no matter what stage of labor or non-labor she is in. She's monitored every 15 minutes.
So we talk about feel a lot. What are we going to feel if there's a placenta?
We're not going to feel anything really significant. Like, we cannot do a Leopold's maneuver and say, oh, I feel a placenta down there. You're not going to feel that.
I mean, if we're checking for a presenting part and labor's not progressing, what will we feel? Is
So
it
you
foggy,
will, if you get through the cervix, then you'll get through the cervix. And then if you hit placenta, it'll just be like meat tissue instead of hard head. And when you check and you hit a placenta, you will cause it to bleed. All right, and then so if she is actively bleeding, we will be monitoring her every 5 minutes. If any OB patient is bleeding, whether they have a previa, an abruption, what they just delivered, and they're bleeding too much, you will be monitoring them every 5 minutes. And depending on the amount of bleeding, she may get a blood transfusion. So if we feel that baby was significantly affected by this bleeding, then we can do some labs on baby. Baby may need a little extra support transitioning, and will probably be a NICU admission. So at community medical center, if babies need any kind of oxygen or IV or anything like that, they get admitted to the NICU. All right, this is not in your book, but this is an important problem with bleeding as well. It's called, so we just covered placenta previa. That means, previa means over the cervix, okay? Placenta means the placenta is over the cervix. And then we had all those different levels of low-lying, complete, partial. So vasoprevia means vessels. Previa means over the cervix. So we have vessels exposed, or we have vessels. So here's our placenta. Here's our umbilical cord. And if you notice in this part of the umbilical cord, it's solid. That means it's covered in the membranes and the Wharton's jelly. Wharton's jelly is in the umbilical cord to provide cushion for those vessels. But in this part, there is no Wharton's jelly. There is just membranes and vessels, okay? Very risky bleed here for both mom and babe, okay? That baby cannot be delivered vaginally. That baby needs a C-section. So this is a very high-risk situation, vasoprevia, okay? Now, placental abruption, or abruptio placentae, is when the placenta separates from the uterine wall prematurely. So if the baby is not delivered and that placenta starts breaking away, that's abruptio placenta, okay? If the baby's been delivered, fine, break away. That's what we want you to do. But if baby is still in utero and the placenta starts separating, we're in big trouble, okay? And there's different, oh wait, so here's your risk factors. Smoking is a big one. Cocaine use is a big one. Well, drug use, but cocaine in particular. And then if she has lots of fluid or multiple babies in there, that's putting stress on the placental adherence. So hypertension, all those things are risk factors. Here's some more risk factors. So if she had an abruption before, we're going to anticipate she has another one. Placental anomaly. So if the placenta is not formed correctly, then we can anticipate that it will separate prematurely as well. Okay, more risk factors. So male sex, I don't know. Boy babies are a big problem. I'm not kidding. Like, you ask any NICU nurse, if she's going to get a bad baby, she's going to pray for a girl. It's just the way it is, dude. Like, I'm sorry. Like, you guys are puny when you're born. You're just puny little weaklings. All right. Okay, so we have different degrees of placental abruption. We have a marginal, where just a little piece of the placenta has broken away. The whole other part of it is still adhered, but this little piece is broken away. That little piece can still bleed and cause a big problem, okay? A central abruption is when the borders of the placenta are still adhered, but the center of the placenta has broken away. This one is a big scary deal because she's bleeding and you're not seeing it because everything is still attached on the outer ring of this placenta, and so the blood is being contained in there. So you don't see this bleeding. And then in a complete abruption is the entire placenta has broken away from the uterus. Okay? And that's really bad as well. All right, so this is just the marginal one. So you can see that this whole piece of placenta is still adhered to the uterus, but this little piece is not, and that little piece is bleeding. Okay? This is your central abruption. You can see the placenta is all adhered on the outer areas, and it's just bleeding right into this little pocket. Okay? And then the complete, the whole thing, and just a massive hemorrhage right there. Okay? Yes?
Is there a way to determine which one you have based on the amount of bleeding or by palpating it?
No, not so much. Now, with abruptions, we palpate the uterus, and the uterus feels firm the entire time, even if she's not contracting. And she doesn't necessarily need to be contracting with this, but she probably is because the uterus is upset. But her uterus will palpate firm when she's contracting and when she's not contracting, and it will be very painful. Okay? So those are your big deals. Constant, severe belly pain, and on palpation, it's firm continuously, and your palpation even is painful. Okay? Now, the hope is if we get someone in, yes?
With like a central abruption, would you still see the physiological signs from the mom of a bleed?
Oh, yes. You will still see those signs, but you won't see blood. Okay? So she'll have the pain. She'll have the bad vital signs. She'll have the firm belly. Now, we'll do a quick ultrasound, and we'll try to determine which type of, whoever asked that question, which type of abruption we have. Now, this doesn't necessarily mean, well, unless it was a complete abruption, it doesn't necessarily mean immediate delivery, because that could clot off and stop bleeding. Okay?
How long do we want to wait?
We don't want to wait very long, because a lot of times we get these after they've already clotted off. So they come in, I've been bleeding, I'm having pain, we do an ultrasound, and they can see that it's either active or clot. Okay? I don't know. I can't see it. But anyways, we put the woman on the monitor if she's doing well, if baby's doing well, and if we feel it's clotted off and the bleeding has stopped, we may possibly send her home. But if we determine that she's actively bleeding, baby's heart rates are bad, mom is starting to look shocky, we will probably go straight to C-section. If she comes in, she's actively bleeding, baby's looking good, mom's looking good, the bleeding is not like profuse, it's just a slow bleed, and we think we might be able to get a vaginal delivery out of it, we might try it. Okay? But as soon as we start putting contractions on an abruption, we're risking abrupting it completely. Okay? So that's that will be a physician decision. But anyways, so, you know, if your mom's bleeding, she could hemorrhage, go into shock, and develop DIC, which I will talk about. Does anybody know DIC? Disseminated intravascular coagulation. It's not just a pregnancy thing. It's anybody who has a massive hemorrhage. Basically, in a nutshell, this is a bleeding, clotting thing all at the same time. Okay, so you're bleeding, and you're using up all your clotting factors, okay? And then at the microvessel level, you're clotting there and also bleeding, okay? Because you don't have any more clotting factors, okay? So you just have a few minor partial of the clotting factors that are doing the clotting, and then you don't have the big clotting factors that stop the bleeding, so you continue to bleed. So it's a horrible, horrible thing. Anyways, so baby's outcome depends on the degree of bleeding and how much that impacted the baby. And if the bleed was significant, baby will probably need NICU admission, oxygen, and blood replacement, okay? So continuous monitoring, continuous assessment of contractions and resting tone. And, we're supposed to always assess resting tone, but with an abruption, if your resting tone is firm and not soft, then you've got an abruption. So we're going to be watching that, okay? Hourly abdominal girths, like I've never done that. I've never done hourly abdominal girths, but if you're having a bleed that's not bleeding out, so you have a central bleed, she could just be filling up, and you could be doing abdominal girths. If this woman is bleeding, and I'm measuring abdominal girths, so how often am I going to measure abdominal girths? Every 30 minutes, every hour? And it keeps getting bigger and bigger. I mean, I'm not going to sit around and measure abdominal girths while her belly fills up with blood, okay? So we're going to do something. But anyways, abdominal girths, you could do that. All right? And then we're going to monitor her coags to make sure that she's not developing DIC. So we need to maintain maternal cardiovascular support, and decide what we're going to do to have a baby. And if she has an active bleed, C-section is probably the safest, okay? Because you're not going to do anything to stop the bleed. We can't do anything to stop the bleed. If it clots off on its own, great, we're in good, but we can't do anything to stop it. But if it, like I said, if the bleeding is not significant, or if she has clotted off, we can try to induce her. All right, so we want to reduce the risk for DIC, disseminated intravascular coagulation, so she's bleeding and clotting at the same time. We type and hold, we cross and hold, whatever it's called, at both hospitals. So we send a tube of blood, and they just hold it in the lab. This tube of blood is for the purpose of if we have to give blood products to any pregnant patient. So we do that on every pregnant patient. But if she has an abruption, we're going to send it to cross-match and have blood ready to infuse, okay? We may need to give other blood products depending on how much blood she's lost, okay?
We throwing clots back into the system? We got to worry about
No,
strokes and stuff?
no, not so much. Okay, there's another complication associated with abruptio placentae, and it's associated with the central, sorry, lost my word, central abruption. So she's bleeding in the center of her uterus, the placenta, and the outer surfaces of the placenta are still adhered. So you're not seeing blood flow, okay, out her vagina. If this is an active bleed, so she's continuously bleeding in this little pocket, there's only so much room that this little pocket will accommodate until it starts pushing blood into the myometrial tissues, okay? And if it pushes enough blood into the myometrial tissues, it's basically tamponading, all that blood is tamponading all those vessels in the uterus. So when you end up doing your emergency C-section, that uterus will be blue because there will be no oxygenated blood in it, because the blood that is being pushed into the myometrial tissues is tamponading off all the vessels in the uterus, okay? Corvulaire uterus. All right, so we're going to be administering fluids and or blood products. If she's lost significant amount of blood, which we've had some patients like this, they go to ICU because they might need central venous monitoring, which we don't, which only ICU nurses do, okay? Frequent lab, they could do frequent lab testing to watch, and they do blood replacement products, okay? Frequent vital signs, we are trying to do our best to measure blood loss. So we have, for every pad that we put under the mom, we have dry weights for, okay? So as she's bleeding, we take that saturated pad and we weigh it, and then we subtract our dry weight, and that's how many cc's, it's grams to cc's, that's how many cc's blood loss she's had. So we can estimate, or we can actually measure, okay? All right, watch urine output. If she's bleeding enough, she's not gonna give any blood flow to the kidneys, and her urine output's gonna start shutting down. Okay. All right. Any questions about bad jujus?
I do. In a situation where you have an emergency situation and mom is deteriorating and baby is deteriorating, who is our priority? Who is our priority patient?
The mom's a priority patient, okay? But as a result, then the baby is like almost simultaneous. There have been situations where we have done post-mortem C-sections to save the baby. So the baby's a priority, the mom's a priority. It's what came first, the chicken or the egg?
Right.
So if you save mom, you have a great chance of saving baby. Okay. But sometimes there have been cases where this was such a critical deal, such an emergency deal, and we went to stat C-section, and we got baby out, and baby went to the NICU and rebounded and recovered just fine. And then mom didn't make it. Okay, so kind of hard question, but yeah, you know, if you save the mom, you have more chances of saving the baby. All right, so now we're going to go on to cervical insufficiency. Cervical insufficiency, or you'll hear it called incompetent cervix. This is where the cervix dilates without contractions. Okay, just probably the weight of the pregnancy on the cervix causes it to dilate. She does not need to contract, and she won't feel any contractions. We'll put her on the monitor and we won't detect any contractions. This is cervical dilation without contractions, okay? So here's the things that put her at risk for cervical insufficiency. Multiple gestations, the weight of the pregnancy, hydramnios is also, maybe it's on the next slide. Uterine or cervical anomalies, okay? So for whatever reason, her cervix is dilating, okay? So yeah, we can watch her cervical length. For women that are at risk, we can start watching her cervical length early and start to see if it's dilating over time. But if it's if we catch it, then we can do. I'm sorry, I'm getting ahead of myself. So serial ultrasounds, bed rest, progesterone and supplements. So progesterone will help support the pregnancy and inhibit labor. She may need to be on antibiotics or anti-inflammatories to decrease the possibility of her cervix dilating. But many times, if we do serial ultrasounds and we're seeing a cervix that's dilating, or if she has a history of cervical incompetence, then we'll do a cerclage. That's the name of the procedure where we stitch the cervix closed. Okay, so it cannot dilate. Ooh.
Does it ever just like,
Break?
yeah.
Yes, it does. I mean, this isn't a foolproof plan, but that's a real extreme situation. And the sooner you put these cerclages in, yes,
I was just gonna say, can they still have a vaginal birth?
yes, and we'll get to that in a minute. The sooner you put these cerclages in, the more successful. So if you find a cervix accidentally that's dilating, and you put the cerclage in, then the risks of that being successful not being successful start increasing. So an elective cerclage. So this is the one that's placed early on a patient that's at risk or has had a previous incompetent cervix. Okay, so they're pretty successful. But if you find a cervix that's already dilating and then you put the emergent cerclage in to keep it from dilating anymore, they're not as successful.
How often, if it's like a person's first pregnancy, how often does you catch it in the first trimester?
You might, so those you usually catch like after it's already occurring.
Okay.
Unless she had significant risk factors like she had a abnormal cervix to begin with, or she had nutrition problems, or she had a large pregnancy. You know, you might go in at that point, but even then, like to just jump in and do her cerclage without really definite risk, they don't do. So usually in the first pregnancy, they find these and place an emergent. The other cerclage is an abdominal cerclage. These are not done. These are done very rarely. So when you're having a regular cerclage, they can go in and some practitioners, it's a surgical procedure. They go in, it's like surgery. Sometimes they're put to sleep. Sometimes they're just giving a really, really good spinal, and they go in vaginally and do this suturing. And then they come back out to the floor. We monitor them for several hours, sometimes 12 to 24 hours. One, to make sure they don't have any bleeding, to make sure that they're not starting to get an infection, that they're not starting to contract. And then if everything looks good, then we can send them home and they can stay pregnant for a long time. The emergent cerclages, they happen the same way. They go in vaginally, but the problem with emergent cerclages is depending on how much she's dilating and how much bulging fluid bag she has, they have to push that back up into the uterus and then stitch it closed real quick. Okay? And that one's very risky. That's one of the reasons why those aren't so successful, because that whole deal right there has just stimulated something. And just the pushing of the bag back up in there might compromise the bag enough that it's going to break. Okay. And then, so the abdominal cerclages, it's a laparoscopic procedure. And they, like I said, they don't do these very often. These are, bad problems with the cervix, or maybe the previous pregnancy she had a cerclage and it wasn't successful, so they're going to do this one, okay? Okay, so this is just saying, this is the emergent cerclage, so we didn't expect a cervical incompetency. We found one, and it's a little more risky for the pregnancy and whether or not it's going to be successful. So when we have these gals, we will give them tocolytics, which is a class of drugs to stop contractions. We will give this either before as a preemptive strike to prevent contractions, or we might wait till after the procedure and see if she starts contracting and then give it. She'll get antibiotics and anti-inflammatories to try to keep everything not developing problems. So it's an outpatient procedure. The emergency clause, they stay a little bit longer just because they've already dilated. We don't know if it's successful. If we had to shove membranes back up there, we want to make sure that the water doesn't break in a day or two or that she doesn't develop infection. And then when she gets to 37 weeks, they cut the stitch. And they can just do that in the office. Okay? And then whenever she dilates and goes into labor, that's good. Okay? So if they plan to do a C-section, it's saying that you can leave the suture in, but they're usually taken out after the section, okay, or during the section. All right, amniotic fluid problems. So hydramnios, once called polyhydramnios. So you might hear that term being thrown around. It's when she has an amniotic fluid volume of greater than 2,000 cc's. The normal volume is anywhere between 500 to 1,500-ish, okay, depending on the size of the fetus and the size of the woman. But greater than 200 is officially diagnosed as hydramnios, all right? So normally the amniotic fluid is produced by urination of the baby. The baby swallows this fluid or inhales some of the fluid, and that helps keep homeostasis of the fluid volume levels, okay? But if there's any problems with the baby, so if baby has any malformations that would affect swallowing, so any mouth problems, any esophagus problems, or even any lung problems where they're not inspiring, could cause disequilibrium in the volume. So these are some other complications: multiple gestations, diabetes, infection. So the treatment for hydramnios, really there's no treatment for hydramnios unless it starts interfering with the health of the pregnancy. So if we have someone who has hydramnios and both mom and babe are doing fine, we will just do frequent surveillance on this pregnancy until delivery. But if it's starting to cause problems with the pregnancy, then we'll do amniotic fluid reductions. So that is an amniocentesis where we draw off large amounts of fluid. And we've had patients where we've done this to them biweekly. She was admitted to our hospital until delivery, and twice a week she got amniotic fluid reductions. Okay, but as you can imagine, you've got this pregnant belly, and now you're adding this large volume of fluid. It's going to start putting pressure on her respiratory system, and mom's not going to be breathing very well. You've got this large weight in her central part of her body that's inhibiting blood flow back from the legs, so a severe edema, okay? And with the weight of that pregnancy, of course, like we're going to risk preterm labor or premature rupture of membranes or premature preterm rupture of membranes, okay? We're going to put stress on our placenta. We could possibly cause an abruption. And if that water did break and you had this whole gush of Niagara Falls coming out of her vagina, it's just going to wash that cord out. So the more fluid she has, the higher risk for umbilical cord prolapse, all right? And then uterine dysfunction and dystocia. We'll talk about what dystocia means here in a minute, but basically what's that saying is that uterus has been just stretched and stretched and stretched. And just like a rubber band that you stretch and stretch and stretch, eventually the elasticity of that rubber band is not working anymore. Same thing with the uterus. You stretch and stretch that fiber so much that you stretch it to the point where it just doesn't want to contract anymore. It's just floppy. So her ability to labor, contract, and dilate is very dysfunctional, okay? And it may not even be able to do it, okay? So same thing with postpartum hemorrhage, same philosophy is she's delivered the baby, however route she's done it, but that uterus is just so stretched that it doesn't want to contract down and control her bleeding. Okay? And then the risks for baby are preterm birth because of the weight of the pregnancy. Now on the opposite side of the extreme, we've got oligohydramnios, which is too small of amount of fluid, less than 500 cc's. Okay, and one of the biggest reasons this happens is some renal problem with the baby. So amniotic fluid is produced by fetal urination. So if the fetus is not producing urine, then we're going to have low amniotic fluid volumes. Okay. So here's all your risk factors. Fetal skin and skeletal abnormalities. So you've got this developing flesh, this pink, moist, developing flesh, and no fluid to hydrate it. So if you don't have fluid, this sticky, fresh flesh is now sticking to things, and it could stick to itself and develop that way. So this could be really ugly problem. Okay, so they're not inhaling or inspiring any of that amniotic fluid like they do normally, so that creates a problem for their lungs. Cord compression is a big problem because the cord is not getting cushioned, so it's being compressed all the time. So what do? We do biophysical profiles and non-stress tests, and we haven't really covered those, right? This semester yet? Okay. Biophysical profiles is basically an ultrasound to look at certain parameters of the pregnancy to see if they're normal. Okay? And a non-stress test is just putting a woman on a fetal monitor and looking at the baby's heart rate and making sure the baby's heart rates are good. Okay? Those are just basic definitions right now until we cover those in class, whenever we do that. So we may be doing ultrasounds often, and if we determine that this woman needs delivered or this baby needs delivered, we might have to induce. Okay? So we can do an amnio infusion in labor. So we've got this woman in labor, we're inducing her because the baby's not looking good. The cord is being compressed because there's no amniotic fluid. So we can do that internal uterine pressure catheter. If you all remember seeing that, that's how we monitor contractions in utero. Okay? That has a port on it where we can infuse fluid into the uterus and temporarily support baby and that cord. It's called an amnio infusion.
What kind of fluid did you have?
Just saline. Okay, any questions about those? So what decelerations will you see on the monitor with oligohydramnios?
Variable.
Variable decels tell us that we have cord compression. Okay. Anybody need a break?
Yes.
Okay. Zoom. All right. All right. Fast like bunny.
Thank you.
Okay, labor-related complications. So this is where we're going to talk about that dysfunctional or hypotonic labor pattern. So dysfunctional uterine contractions causes dystocia, and that's just a difficult labor. You might hear the word shoulder dystocia, so difficulty delivering the shoulder. Okay, so dystocia just means difficult, basically. Another term you'll hear is tachysystole. That's more than 5 contractions in 10 minutes. So when we're running Pitocin, our goal is to get 2 contractions, or to get a contraction every 2 minutes, which another way of saying that is to get 5 contractions in a 10-minute period. Okay? But if we have more than 5 contractions, then that is termed tachysystole. And you might hear some of the older nurses saying hyperstimulation. We're not supposed to use that word anymore, okay? And then the hypotonic labor is less than 2 to 3 contractions in a 10-minute period. So you're contracting, 4 to 5 minutes, every 4 to 5 minutes or so. Now, some women who are not on Pitocin are contracting 2 to 3 times in a 10-minute period, and they're dilating and doing just fine. Okay? But typically, if they're contracting only 2 to 3 times in a 10-minute period, you're not having a functional labor. Okay? Some women who are not on Pitocin will contract more than 5 times in a 10-minute period. And if baby's tolerating that, we're going to let it go because that's a natural pattern for her. But if baby stops tolerating that, then we'll have to intervene. Okay? So the top, number A, is a normal contraction pattern. 1, 2, she's contracting about every 2 to 3 minutes. Number B is she's contracting too often, so she's contracting about every minute here. Okay? She's not getting a break. She's having that pain every 60 seconds, and baby's not getting a break. That uterus is contracting, so it's decreasing blood flow to the baby. That's a normal process with a contraction. But if you do it every minute, then baby's going to get tired out. Okay? And number C is that hypotonic labor pattern where she's contracting less than 2 to 3 contractions every 10 minutes. Okay? That's what those patterns look like. So your risk for tachycystole, of course, is increased discomfort and fatigue. Mom's going to wear out. Those contractions are happening so often that they might not be effectively dilating her. They may be. So she's going to get frustrated and stressed out. She's going to get dehydrated because she doesn't have a chance to drink because she's constantly in a contraction. Okay? So here's all those risk factors. So what do we do to treat tachycystole? Bed rest and sedation. So we could give medications to quiet her down, quiet that uterus down. If we're running Pitocin, we can turn it off, or we can give her a bunch of IV fluids. Okay? So we do our assessments on our contractions, our vital signs, and our fetal heart rate. Do what we can to support mom's ability to deal with this pain. She may have an epidural, which is great. Change positions, warm showers, sedation, pain medicine, and IV fluid. Okay, it's not on there, but IV fluid is a great treatment for tachycystole. Okay, remember when I said the uterus is very sensitive to dehydration? So even if she's not dehydrated and she's got a tachysystolic pattern, throwing some fluid at that uterus might quiet it down a little bit. So a hypotonic uterus, so this is the one that doesn't want to contract. So we talked about that uterus being overstretched. Twin gestation is listed up there, but for any reason it's overstressed. Okay, maybe we got a super huge baby in there. Or maybe we've got a lot of amniotic, large fetus, hydramnios. Read the slides, woman. Malposition, bladder and bowel distension. So full bladder is a bad thing for a pregnant person. Okay, keep her bladder empty. And cephalopelvic disproportion. What cephalopelvic disproportion is cephala is head, so baby's head and mom's pelvis, it's a square peg in a round hole. Okay? It's not going to work. This hypotonic contraction pattern goes on for decades, and of course, mom's going to get exhausted. She's going to get stressed out because she's not going to be dilating. Now, she finally delivers the baby, either vaginally or C-section, and because of that over-distended uterus or those hypertonic contractions, so they're still hypotonic after delivery, so they're not contracting to slow down the bleeding, okay? So she could be at risk for hemorrhage, okay? All right. Questions? I'm going fast. What are we talking about here? Post-term. Okay, post-term babies. Post-term, oh, I don't have the picture on here, which is really bad. I think it's presented in when we start talking about baby cares. Post-term babies, very ugly babies because they start wasting because the placenta starts being dysfunctional and not supplying nutrients and oxygen. And sometimes post-term babies, depending on what their how much they've been deprived, can be born looking like, what was that show where Brad Pitt was born old? Okay, they can look like a little tiny old wrinkled man because they've lost weight. They're wasting. Anyways, I gotta go fast. Quit being silly. Post-term. So the other thing with post-term is the placenta may be functioning just fine and it will live forever. And this baby is 3 months old in utero. Okay, so we've got this super huge baby. So post-term, we could have a dystocia type labor pattern because baby's too big. Okay, we could have a cephalopelvic disproportion because baby's too big. We might have to use forceps or a vacuum to get that monster out of there. Okay, so perineal trauma, if that baby's big, could just split her from stem to stern. She may have to have a C-section, and of course, hemorrhage for the same reasons that we have an oversized, overstretched uterus. Okay. Okay, so on the other side of the coin, so we have decreased placental perfusion because those placentas really only live for 40 weeks, okay? And then they start deteriorating. And as they deteriorate, their function deteriorates. So therefore, baby is not getting nutrition and oxygen. So we could have, we could have babies die in utero. We could have babies stressed because baby's oxygen deprived and has meconium in utero. Of course, low APGAR scores, sudden infant death, all these things, okay? All these bad things for baby. Dysmaturity syndrome, so that's the baby that is born looking like a 90-year-old man because it's a wasting baby, muscle wasting and stuff. Small for gestational age. So for a post-term pregnancy, so after 40 weeks, if she hasn't gone into labor and she doesn't want to be induced, which most docs are going to want to induce someone who's getting close to 40 weeks, if she refuses that, then we're going to do bi-weekly assessments on her and baby. And that's twice a week, okay? So as long as baby is doing well, then we'll continue to let this go on. But once they hit 41 weeks, then they're going to be like, we need to induce you. You don't have a choice. Your baby's not going to make it. We gotta get the baby out. Okay? All right. That was fast. Questions? Okay? Post-term is not always better. All right. Another problem in labor is a malposition of the baby. So ROA, OA, LOA. So what does R mean?
Right.
What does L mean? What does O mean? What does A mean? Is that a good position to be in? Yes. Those are good positions to deliver in, okay? Those are great. That's what we want. One of those, okay? Basically anything with an OA, occipital anterior, okay? So the back of the head is to the front of the woman, so baby is born face back, face down, and out she comes, okay? But an OP delivery is the occiput is facing mom's rear, and the baby's face up, or you've heard sunny side up. Okay, that can be a vaginal delivery, but because of the shape of the baby's head compared to the shape of the pelvis, it's going to be a little harder. Mom's going to have to, if she is exhausted from pushing, she's going to have to find some juju because she's going to need to push harder. Okay, and it seems to be a more painful labor because if the occiput is posterior, what is the occiput pushing on? Okay, all these nerves and muscles in her back. So she feels more back labor and typically feels more pain than the other woman who has the OA baby. All right, so So with persistent occiput posterior or an OP baby, persistent just means baby was delivered that way. It stayed that way. We couldn't get baby to turn, okay? But basically it's an OP baby. This could split mom perineal-wise. This can really cause some bad lacerations, okay? And depending on what we need to do to get that baby out, how long that baby's been in the vaginal vault, head compression, if we had to use an instrumented delivery, meaning we had to use forceps or a vacuum, those have risk factors to babies on top of it. Okay, so we watch the progress, choose between vaginal and cesarean birth. You know, unless it's a square peg coming through a round hole, she could do a vaginal birth, okay? But it's just going to be harder. And she may, you know, I've had women who are pushing, and that baby's OP, and she has no more juice. She's not going to do it. Okay, we've gone to C-section with a woman who's pushed for however long. So, and then, you know, we may need to use vacuum and forceps, which will present its own problems. All right. So one thing that we can do in labor is if we feel like that baby is OP, we can change mom's position, and sometimes that will encourage baby to move. Having mom on her hands and knees laboring is a great way to get baby to reposition. Okay. I hate it. Oh, I'm going to talk out both sides of my mouth. I love it when a gal has an epidural. Okay. It's a lot easier on me as a nurse. Okay. I just go in, I turn her, I clean her up, I do my charting. Okay. Go out back, have a cigarette. Okay. But if she, so if she has an epidural, you can't put her hands and knees. Okay. Because of the fact that, one, she may be able to like get a good position and stabilize like that, but if something starts slipping out, she could cause trauma to all her flexors and tendons in her hip joint because she don't know she's doing it. Okay, so this is very hard to reposition someone who has an epidural. So that's where we use that peanut ball. Okay, it's a big ball about this long, about this wide. We put it between mom's leg and we keep turning her from side to side. This will encourage baby to rotate. Okay, I am not the labor nurse that gives my patient an epidural and then checks out to the end of the shift charting off the monitor. Okay, if she's left to lay there on her back, that baby ain't gonna do anything right. Okay, she needs to be turned. But if she doesn't have an epidural, we can get her to labor for 15-20 minutes on her hands and knees, maybe labor on her side, get her up on the birthing ball, get her up walking, make this woman move, because that might encourage baby to turn. Oh gosh, come on, let's keep going. So we're changing position. So we know the occiput is the normal presenting part. There's other, whether it's OA or OP, there's other malpresentations that we want to take a look at. This does say that unless you have an occiput, you don't want to be putting an internal scalp electrode on a face or a baby's butt. Okay, so, all right, so this is normal. Okay, when that head comes down through the vaginal vault, this is the smallest diameter of that head. So if that head changes position in any way, this is military. Look at the difference. Did you notice it was 9.5 centimeters the other way? 12.5 centimeters this way. Okay? This is like trying to push a melon through a golf hole. There's your face presentation, even larger. Well, it's forehead, actually, because here's your face. Okay? And this can be delivered vaginally, but what's going to happen to all these structures when that baby comes raking down through the vagina? Okay. Here's your breech presentation. This is called a frank breech. There's other breaches we'll see, but frank breach is when both feet are up and all you got is butt. Just plain butt, okay? A footling breach, 1 foot's coming down. Okay, so breech presentation, usually not delivered vaginally. However, there are cases where stuff happened and either this person came in precipitous delivering, 10 centimeters, she walked in the door and a foot's hanging out. So you might be able to get to the OR, you might not. But anyways, if we have a person coming into labor and we do our vaginal exams and then we feel for a presenting part, if there's a breach, we need to identify it right then and there, okay? Because we can attempt to do an external cephalic version. That means turn the baby head down. However, the more turn you get and the more labor you have, the more difficult a turn is going to be. If you're more term, you have less room. And if you're contracting, you're fighting the forces of a contracted uterus to try to turn a baby. So it's very difficult. So if we can figure out if the baby's breech in this 36 to 38 week window, then we can schedule an external version and try to turn the baby, okay? So that when she does come into labor, she will have a better chance of having a vaginal delivery. But if for whatever reason the baby's breech, we turned it, baby turned back, or she didn't want to turn, or whatever, it's a C-section, okay? Transverse lie, that's where the baby is laying this way, and you've got a shoulder down in the pelvis. That's your presenting part, okay? You can try to turn this, but again, if you can't get it turned, it's a C-section. There it is. Look at the shape of her uterus. You can almost see a transverse lie without doing Leopold's maneuver. All right, questions? Macrosomy, big baby. That's what it means, big baby. Greater than 4,000 grams, okay? There's a lot of risks with a big baby. They're fat and cuddly and you just want to squeeze them and kiss them all over, but they might not fit through the they might not fit vaginally, just depending. And if they do fit vaginally, they may bust mom up all the way down, okay? But postpartum hemorrhage is a risk because of this overstretched uterus because of this big, huge baby, okay? Here's some other things that may happen. Shoulder dystocia. Jason can tell you about this. You've got this big baby and you do get that melon through the vaginal canal, but you can't get those football shoulders through the vaginal canal. That's called shoulder dystocia. What happens is, this is the pelvis, okay, and the head comes down under it, but the shoulder gets caught on it. It ain't getting down through there, okay? That's called shoulder dystocia. It is an obstetrical emergency. If for some reason you release the shoulder dystocia, and there's techniques that we can do to try to release that, is you can damage anything right here on the baby. Okay, you can break a clavicle, you can damage all these nerves, you can dislocate a shoulder. So the procedure is if this is mom's pubic bone right here, this is her abdomen, this is her vagina, the shoulder's right here. So what the nurse does is they take mom's legs and as close to her ears as they can get with those legs. That helps open the pelvis a little bit. And if that doesn't work, then the nurse takes her, can everybody see me? The nurse takes her hand, her fist, got it? Takes her fist on mom's pubic bone, so now I'm also on baby's shoulder, and I'm pushing down, and the doctor will tell me this way or that way, and as I'm pushing down, I'm pushing towards that direction. So what I'm trying to do is this. I'm trying to do this to baby. I'm trying to collapse those shoulders, and in the process, I may break this bone, I may dislocate this shoulder, I may damage all these nerves and tendons here. Okay? Yes?
In the labor that I was watching, was the OB concerned about that shoulder dystocia because of things that he had seen in in prenatal care, or because he was seeing it starting to stall?
I don't know. I don't know what his. So what I think one of the things he was seeing is what we call turtle sign. So here's the vaginal opening, and you've got the head crowning, turtle, head crowning, turtle, head crowning, and what happens is a woman pushes, and then she stops, pushes, and baby kind of relaxes back. So that's kind of a normal thing. But when head comes and then comes back in and comes back in, then that's called turtle sign, and that means that, yeah, we're pushing and extending all this, and then she stops pushing, and that shoulder's not going anywhere, so it comes back, okay? So during this process of trying to get this baby out, baby can become asphyxiated. Now, the other thing is hypoglycemia. Yes, I'm sorry.
So he did an episiotomy and the kid came right out after
Right.
that. If he had done the episiotomy and the kid still kept doing that, then
Then it was
you guys
definitely
would
a
have
shoulder.
gone into the
So we
operation.
did. So in Jason's delivery, we prepared for a shoulder. Okay, but it wasn't a shoulder. It was just, it was a big baby. Was it a big baby? I don't know.
It wasn't that big.
It wasn't that big. So we prepared for a shoulder. That's great. It's always great to be prepared and not have to act, than to not be prepared and have to act. So, anyways.
It was pretty cool, you guys. Like, I could tell Wendy and the other nurse, whose name I forget, Nikki, I think. Like, I could tell the doctor said something, and then they were like getting ready, and like they didn't say anything. I was like, oh my gosh, something just changed. What's going on?
Yeah.
How many pounds was the baby?
I don't know, 6 or 7 or I don't know. Yeah, it wasn't huge. I don't know. But anyways, yeah, it was fine. So the baby's been born, and now the baby's at risk for hypoglycemia. Why is a big fat baby at risk for hypoglycemia?
Not being supplied by the placenta.
He's not being supplied the sugar that he's normally accustomed to. Okay? And the sugar that he's normally accustomed to, he has been creating insulin to handle. And now he's got all this insulin and no sugar to act upon. So it depletes his sugar. Okay? All right. So all these things. I've got to start going faster. So if we determine that we have a macrosomic baby, then we maybe want to induce this woman before baby continues to put on large amounts of weight. However, we still can't induce before 39 weeks. Macrosomy is not valid early induction. Okay, so ACOG, American College of Obstetrics and Gynecologists, have put out a recommendation when you can induce and when you cannot. You have obstetrical and medical reasons to induce before 39 weeks, and if you don't have those, you don't induce before 39 weeks. And macrosomy is not one of those things. So we still got to wait to 39 weeks. We can estimate fetal size on sonogram, but it is plus or minus 2 pounds. Okay, so you can think your baby is 10 pounds when really, then actuality, it's only 8.
Or 12.
Or minus, or the other way. Okay. So anyways, but the woman could say, fine, I'm not going to do a vaginal delivery and you ruin my life. Cut me open and do me a C-section. Okay. All right. Okay. So we try to identify who's at risk, try to stay on top of it. Okay. Continuous monitoring, blah, 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 watching the labor. Just remember, with a big baby, we can have problems with our labor, we can have problems with our delivery, and then we can have problems with our poor mom afterwards, and then problems with our poor baby. Okay. Okay. On and on we go. Moving along very quickly. So overstretching the uterus, I told you about that. Not the uterus not wanting to contract afterwards, and so therefore we have bleeding problems. Okay, blah 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 blah, non-reassuring pattern. So this is not really related to any type of disorder. Okay, this is just we're laboring this patient and we have bad baby heart rates. We call that non-reassuring fetal heart rate status. Okay, so for whatever reason we have those. Okay. We could have persistent late decels, or what's the other word we call decelerations that happen persistently? Recurrent? Recurrent, persistent, severe, variable decels, prolonged decels, and loss of variability, okay? Tachycardia and bradycardia are not good, okay? So what do we do to help non-reassuring fetal heart rates patterns? Okay, we poison our patient. Not necessarily in this order, but we poison our patient. So we put, first thing we do, period, first thing we do is we change mom's position, okay? We can supply oxygen, we can supply more IV fluid. We're trying to get more blood volume and more oxygen to the placenta and therefore to the baby. We can do a serovaginal exam, maybe that tells us what's going on. We can stop our Pitocin for sure, and then we can call our provider, notify our provider, okay? So some of these things are happening simultaneously. So I go in and I reposition mom, I reach over, I crank my IV fluid up, I turn off my Pitocin, I take another step, and I grab my oxygen, okay? So all these things are like happening within a few seconds of each other, okay? Everybody got this one?
Not yet.
So IVF is increased.
It's just IV fluid. So we want to increase it. We want to start IV fluid, whatever we need to do. We want to get some IV fluid going. And we want to make it go fast. Oh, I've got 5 minutes.
So if you have a patient who comes in at 37 or 38 weeks and it's estimated they have a 10 or 11 pound baby, and they say, okay, well, I want to do a C-section right now. Can you schedule a C-section then, or do you have to wait till 39 weeks to do a C-section?
We would have to wait for 39 weeks. So not only can you not induce before 39 weeks without a medical or obstetrical reason, you can't do a C-section. Okay. All right, I'm going to end up. I don't want to fly anymore. I don't have time to fly. So I will finish my recording this evening. Okay, for those of you who care about the recording.
So quick question, is the difference between a
Macrosomia?
macrosomia and an LGA just the weight?
Yeah, so macrosomia is, period, any baby, any gestation greater than 4,000 grams. Okay? LGA babies are large for gestational age. So that could be at any gestational age, they're born, but according to the norms for that gestational age, they're larger. You see the difference there? So my baby could be born at 32 weeks, and my baby could weigh 6 pounds. That is large for a 32-week baby. So baby is large for gestational age, but baby is not over 4,000 grams, so it's not macrosomia. Okay? Usually if your baby is macrosomia, usually it's large for gestational age because it has to be over 4,000 grams. So if baby's born at 38 weeks at 4,000 grams, I guarantee you that's large for gestational age because 38-week babies are not 4,000 grams. Okay, so that's where they can be the same thing. All right, another thing you might hear when we're handling non-reassuring fetal heart rates or we're poisoning our patient, we're actually doing intrauterine resuscitation. When we give oxygen, IV fluids, maternal position change, we're actually providing intrauterine resuscitation. Okay. So you might hear that term flown around, all right? So down here at the bottom, fetal scalp stimulation or fetal acoustic stimulation. So if we have a baby who's not doing well, and we think, well, if we just stimulate this baby, maybe this baby will go, oh, right, I'm supposed to live and be married, okay? So that might be a great thing to do. However, if your baby has intrauterine placental, oh my gosh, guys, my brain has stopped. If your baby is not getting good resources from placenta and baby's just not living well at all, and you stimulate a sick baby, are you going to make him better or are you going to push him over the edge? So this is very controversial when you can use this and when you can't, okay? Anyways, we'll just go ahead and stop there, and I will go home tonight and finish recording, okay, for Rachel. Oh. No, I'm not. I need to finish lecturing you guys, so I will finish it, but it won't be till this evening. This first part will probably be up within a couple of hours. Okay?
Can you elect to have a C-section?
Uh-huh.
Just like, I ain't even gonna try.
Yep.
As long as not before